This from breast, prostate, and colon. In year 2013, it accounted for nearly 160,000 deaths. So this is a very serious cancer. The screening does matter because the purpose of the screening is to detect early cancers. For lung cancer in particular, if the cancer is localized, the 5-year survival is around 54%. For more advanced cancers, the prognosis is dismal and it falls down to around 4%. So when you're looking for a screening test, there are few set parameters which qualify this to be an ideal screening test. The first and foremost, a screening test should detect a cancer at a curable stage, 1. It should also decrease the disease-specific mortality, so the death from cancer itself should be reduced. Then, the complications from screening test should be minimal. Not only that, the workup which follows the follow-up screening test should also be associated with very fewer complications. Furthermore, the test has to be cost-effective. When you are implementing a large-scale screening trial, we should always be aware the implications of the clinical practice. How does it function or affect the clinical implementation? So having laid down these basic rules for a screening test, let us look at few studies which led to NLST. The first study which is of interest is the screening by chest radiograph and lung cancer mortality. This is derived from PLCO, which stands for the prostate, lung, colorectal, and ovarian randomized trial. This is a mammoth study, which included around 150,000 patients. It was done between 1993 and 2001. The patients were followed for 13 years. In this study, the patients were randomized into two groups. One group where the patient had annual screening chest X-ray. The other group received regular clinical care. This study was very interesting because it proved beyond doubt that screening chest X-ray is not useful in reducing lung cancer-specific mortality. In the screening group, there were 1,213 cases of cancer deaths. In control group, there were 1,230. So statistically, it was a washout. The second study, which is a revolutionary study, for the first time, it demonstrated convincingly that low-dose CT scanning is very helpful in increasing the survival. This study was designed such that every patient who was enrolled into the study underwent low-dose CT. There was no real control arm, so we cannot derive any cancer-specific mortality reduction rates. So this study was done by LCAP. LCAP was a popular study group which was based in New York Cornell Hospital. This is an international study. They had sites all over US. They also had sites in Europe, Israel, and Japan. So this study enrolled around 31,000 patients, and it was done between 1994 and 2005. And there was no control arm. The age varied. The patients were ranged from 40 to 86 years, and the smoking history is also not consistent. They allowed lower smoking history for younger patients and higher smoking history for older patients. The interesting result is 85% of the cancers that were detected belonged to stage 1. Not only that, when these patients underwent complete surgical resection, the 5-year survival rate was astounding 92%. Compare this to stage 1 cancers that are detected outside screening. The 5-year survival is around 55%. So this showed that we are detecting more early stage cancers. Not only that, the survival is much better when detected during screening process. So this is a landmark study, but because there was no control arm, we could not derive cancer-specific mortality rate. So that is one of the criticisms for this study. Now comes the most landmark study of lung cancer, perhaps in this century so far, that is the NLST. NLST showed there is reduced lung cancer mortality with low-dose CT screening. This is a very big trial. This study included over 54,000 patients, and this study had two arms. The number one is the low-dose CT. We also had a control arm which screened the patients with chest radiographs. This study showed 20% fewer cancer deaths when screened through low-dose CT. The cancer detection rate was 2.4%. For 320 scans or persons scanned, they detected one cancer. So this study had some drawbacks. There were a lot of false positives, around 96%, but the risk of death from non-lung cancer-related events was very minimal, 0.02%. So again, some of the inclusion criteria. The study was done between August 2002 to September 2007. The age group was 55 to 74. They were more strict with their smoking criteria. The criteria was at least 30 pack or more. The patient should not have quit the smoking in the last 15 years. All patients underwent 3 rounds of screening. They had a baseline screening or randomization screening, followed by a screening at 1 year and a subsequent screening at 2 years. As I mentioned, this patient had 2 different arms, CXR and LDCT. The results were astounding. The results were very convincing. It showed 20% reduction in lung cancer mortality. The cancer detection rate was 2.4%, and the rate of positive screening test for CT arm was around 24.2. For X-ray, it was around 6.9. But beyond this, it had another important message. All-cause mortality, that is, causes of the death other than lung cancer, also have decreased by 6.7%. This is something which was unexpected, so this was a very interesting observation from this study. This study was very comprehensive. They have not only looked at the lung cancer-specific mortality reduction, but they also looked into the complications that resulted from working up these positive lung nodules. So they looked at complications from thoracotomy, complications from bronchoscopy, and also needle-guided biopsies. The complications are very few. You would assume that patients with emphysema, with heavy smoking history, would have higher complications, but that was not the case. The mortality for diagnostic workup was around 1.5%, and interestingly, there was 1 death reported from percutaneous biopsy of a lung nodule. Now this leads to another interesting trial, Nelson trial. The reason I included Nelson trial is, Nelson trial is the second largest randomized control study, and this study is more recent. NLST was in 2011. If it is a good study, subsequent trials should also support the findings. Nelson was published in 2020, and this study was designed such that there was a CT arm and there was a control arm. The control arm was just usual clinical care. There was no chest structure done here, but there were 2 separate arms. The mortality reduction was 26%. When they conducted this study, the participants were predominantly male. Over 90% of the participants were male, so the female were not well represented. So when they published the data, they wanted to classify the data based only on the male participants. So I want to compare here Nelson to NLST. There are a lot of similarities. Nelson is a slightly smaller study, 15,000 participants, compared to NLST, which was around 54,000 participants. The inclusion criteria were more or less the same. The age group is the same. The smoking history is the same. The NLST used 15-year cutoff for smoking cessation. Nelson used 10 years. There were more screening rounds in Nelson, but their protocol was slightly different. They did not do annual screening. They did randomization, year 1, year 2. Then they doubled the interval to 4 years. Then they added a 6.5 years. The important difference was how they defined a positive nodule. For NLST, we used bi-axis measurements. Anything which was 4 or more was considered a positive nodule. Nelson was different. They used volume. For them, a positive nodule was any nodule that is 500 cubic millimeters, or a nodule that has grown a growth of 25%, or a nodule that has a doubling time of less than 400 days. Based on this criteria, there were slight differences, but overall, the results were pretty similar. If you look at this graph again, it shows the early cancers in Nelson trial were also very high. It was close to around 60%, which is similar to the NLST trial. And in the screening group, there were far higher deaths compared to far fewer deaths compared to the control group. There's a mortality reduction of 26%. If you remember, NLST showed a mortality reduction of 20%. And the only criticism for the study is it did not include enough females, so the data was mostly for men. When they reported the data, they did not address the mortality reduction in the females, but a subsequent subgroup analysis showed that the mortality reduction in women was even more profound. The mortality reduction was in the range of 60%. So there are some differences. Nelson basically focused on growth rates and based on the volume, whereas Nelson was bidimensional and mean of the bidimensions. And Nelson predominantly included men, whereas NLST was more balanced. And there are differences in the rounds of studies, screening studies which were done. But if you ignore these subtle differences, there are a lot of similarities. Both showed detection of early cancers. Both showed predominantly low-stage cancers. The one important limitation of Nelson trial was it did not address the complications that were a result of the nodule detection. As you know, when you do lung cancer screening, we pick up a lot of false positive nodules, and whether we like it or not, we are forced to follow up these nodules, either by subsequent imaging, or some of these nodules undergo further investigations. These do result in some complications. This particular aspect was not addressed in Nelson. Having said that, these two studies are clinical trials in a controlled environment. The real validity of a clinical trial is seen in clinical practice. So I wanted to focus one more study here. This is a retrospective study, single institutional study done from MGH. I was the lead investigator on this one. So if you look at the timeline of the NLST trial, the study was published in 2011, and this was incorporated into the clinical practice, that is lung cancer screening, by year 2014. And at the same time, the ACR released the lung rats guidelines. This is a specified way to report the findings which are detected on low-dose lung cancer screening study. If you look at this study, the study is slightly different in the sense when the study was approved by the CMS, they extended the age range. The NLST was for 55 to 74, whereas in clinical practice, we extended up to 80 years. We looked at around 4,000 patients, and we looked at the scans which were done between 2014 to 2019. We published this data in 2021, so we followed these patients an average of 6 to 7 years. So this was our results. So we detected around 158 patients with lung cancer. So because this was a clinical practice, we ran into some problems. The American College of Radiology was very good in resolving these issues. Because people use different types of scanners, the technical parameters were set such that the quality of the images would be uniform across different sites. And we used lung rats criteria to report the findings. So that was also a very good factor which resulted in consistency of reporting. So in this study, again, just like NLST, we wanted to look at surgical and non-surgical treatments, complications, pathology, and we also gathered some genetic data. When we talk about lung cancer screening, today we have to talk about lung rats. Lung rats stands for lung CT screening reporting data system. It is a lexicon which assigns a number to the lung nodules that are detected on lung cancer screening CT. The numbers range from 0 to 4. The categories 1 and 2 have almost very low risk of cancer. They're considered benign nodules, whereas category 4 nodules have high prevalence of cancer, range between 5 to 15%. So these are actionable nodules. These nodules need to be worked up. And the category 3 falls in between, but majority of the nodules in this category, again, are benign nodules. So compared to NLST, if you compare this study of 4,000 patients, the largest study done after implementation to the clinical practice, there was even astounding benefits of lung cancer screening. One, the cancer detection rate was 3.8%. It was 2.4% for NLST. The stage 1 cancers were even higher, around 71%, compared to 54% in NLST and around 60% in Nelson. The mortality rate was also lower, 0.45% in this study compared to 1.33% in NLST. So all these were very encouraging signs, which suggest that we can successfully implement lung cancer screening in clinical practice with equally good results. Most of the cancers were stage 1A, and most of the cancers which are screen detected tend to be adenocarcinomas. The most common diagnostic method was VATS, thoracoscopic lung resection, followed by endobronchial ultrasound, and finally needle biopsies. It's very interesting that when we started this trial, our assumption was that we will be doing more needle biopsies, but that was not the case because these nodules tend to be smaller, not easy to target, and there's also a lot of emphysema that increases the risk of pneumothorax. So most of this end up going for VATS resection. The treatment and mortality of this group. Most of the patients ended up getting only surgery. That was the only treatment they required. They did not require any adjuvant chemotherapy or radiotherapy, and this surgery alone accounted for around 2/3 of this patient. And not only that, most of the procedures were done through a thoracoscopic approach. Therefore, it was a minimally invasive procedure that resulted in fewer complications, shorter hospital stay. And some patients received radiation therapy only because these patients refused for surgery, and very few patients had to go on to get adjuvant therapy or a combined radiation and chemotherapy. One of the other aspects of lung cancer screening is, because we cover so much of body area, we include other organs, there is also significant detection of other findings. So one thing which was not addressed very clearly in NLST was incidence of extrapulmonary malignancies. In our study, this is around 0.48, roughly 0.5%. There are other clinical trials like Italian lung trial, which also demonstrated higher incidence of extrapulmonary malignancies similar to our range. So the most common malignancies are that of breast, kidney. We had 2 cases of pancreatic cancers and few from liver. The most important thing is these incidental findings take up a lot of resources. Working up these incidental findings, like a thyroid nodule or a liver lesion, kidney lesion, leads to a number of more investigations. So we wanted to assess the cost for these additional investigations for additional malignancies that are detected outside the lung. The cost was around $13,000. When you take the quality assessment, it was pretty reasonable. The other thing we report on lung cancer screening study per lung rats is the significant findings. The significant findings could be suspicious findings in other organs, and more commonly, what we report is coronary artery calcifications. Any coronary artery calcification that is moderate or severe has a bearing on cardiovascular events, therefore we report them. So in this case, we wanted to see the impact of reporting so many significant coronary artery findings. To our surprise, 80% of the findings which we call significant did not result in any intervention because the clinicians were already aware of these cardiovascular problems for these patients. They were already being treated with antihypertensive medication, or they were already getting statins to lower their cholesterol. So an additional intervention was performed. In 20% of the patients, however, additional intervention was done. But most of the intervention was minor in the form of pharmacological therapy. Either they started this patient on statins, or they increased the dose of statins or antihypertensive medication. Very few patients required a major procedure, like a percutaneous coronary intervention or coronary bypass graft. And some patients went on to get echocardiography, but that's about it. So this is a weakness of this study. It's a single institutional study, but this does prove that the results of NLST could be translated into the clinical practice. Thank you.
Thank you, sir. It was indeed a very lucid presentation on NLST. And although your topic was only NLST, but Nelson also you explained very nicely. However, I would like to put across an idea in everybody's minds Nelson as well as NLST both had N of 55,000 something in NLST and approximately 15,000 in Nelson. And they are supposed to be landmark studies with robust screening and protocols and sample size. To put a seed of idea in Indian minds is also very important. Research, publishing is not for instant gratification. You develop a protocol, you go ahead, do cases, it will not maybe benefit you in your lifetime. But as we see protocols, as we see screening trials, standard trials, they have been done by somebody. And being the second most populous country, shying only China, I'm sure 50,000 is nothing for us to meet if multiple institutes come together and start a protocol for a screening trial. That would benefit Indian population and eventually world as well. So thank you so much, sir, for inciting those thoughts in our minds. And conferences like SOIICON are aimed to do that in Indian setting as well. Thank you so much.
Thank you.
Excellent talk about the NLST. Just a few comments here. One is that the screening guidelines for lung cancer by the United Services Preventive Services Task Force have been revised. Recently, they have been revised. There are multiple reasons why the guidelines for screening also get revised. As far as lung cancer screening guidelines are concerned, the age criteria, basically it's considering only two risk factors. One is the age criteria and the other is smoking. It doesn't address the risk of lung cancer in non-smokers at all. A substantial population in the Asian countries is actually non-smoker, and they get lung cancer. At the same time, a substantial population in the United States and in the Western countries, which does not qualify for lung cancer screening because they are younger, they get lung cancer, particularly in the Black or Hispanics. So there are a few gaps which have to be addressed. And maybe in the future, there'll be many other factors will be taken into account when recommending screening, like your racial background, like your family history of lung cancer. Right now, that is not being taken into account for lung cancer screening. And maybe a genomic profile if it is known. So these are the factors which may have to be taken into account. It is expensive to do screening. That is why for screening of any cancer, there are 3 or 4 very basic minimum requirements. One is it should have a higher prevalence in the population. There should be an easy test to detect it. And the third is that it should be treatable when detected. Many cancers will not be treatable even when they are detected early, and so screening will not apply to those cancers. So there are many gaps, and I think in the future these gaps will be addressed. If anybody has a question or a comment from the audience, please. Yes, Dr. Shiv Kumar.
Where do we stand in terms of lung cancer screening in India? Currently, with all the guidelines, whatever the US says, it's strictly for the smokers and the age.
Excellent question, Dr. Shiv Kumar. Along with the thoracic surgeon in my institution, 4 or 5 years back, we laid down some guidelines. And then we had a brainstorming session, and we thought what all to include. So we included alcohol consumption, gutka, chewing, because all these contribute to lung cancer. And we brought down the age also much, but actually it is very expensive. And as was pointed out in that study also, you end up finding a number of incidental issues, incidental problems which have to be addressed separately over and above. And maybe those issues will not present in the patient's or the individual's lifetime if they were left alone. So that's an additional cost to the state or to the individual. And at present, there are no guidelines in India. No, actually, the screening guidelines as far as the government is concerned in India, since we are talking of screening, is only and only for 3 cancers. It's for breast cancer, but not mammography. It's clinical breast examination only. You can't afford to do mammography for the masses. The second is oral cancers, which is only an oral examination, a clinical examination. So the white paper addresses these two and cervical cancer, that is a pap smear. The government of India doesn't actually recommend because it cannot afford. Once you recommend something, the government has to provide for it. If the government is not able to provide, they recommend only these three and not mammography, clinical breast examination, oral examination, and pap smear. But all screening, the prevalence has to be the first thing, then only you'll detect more cancers. It should be detectable early, and most importantly, it should be treatable. If you detect pancreatic cancer early, you find some way of detecting pancreatic cancer, you can't treat it because the outcome will be the same, there's no point screening. So screening is under debate whether prostate cancer with PSA or breast cancer with mammography also in many countries is debated. And lung cancer, of course, it is, at present it is risk stratified only to the extent of smokers and age. But there are many other risk factors which are not taken into account. Any comments from you?
The criteria for selecting a particular disease for screening is based on quality adjusted life years. That's a metric which is derived. And usually the United States Preventive Task Force takes into consideration the quality of life which is saved. It should be less than 100,000. So if you take the quality numbers and the rough cost for saving a lung cancer patient with lung cancer, it is actually cheaper than for breast cancer and colon cancer screening. But as you pointed out, there are other problems. A breast cancer is a very focused examination. The chances of finding incidental findings unrelated to breast cancer are limited. Whereas for lung cancer, the problem is we screen a large area of the body, which also includes other organs, so the false positives increase. So that should be the reason why we should be mindful of the cost. But these two studies, particularly NLST trial, did show that the cost is very low, so it's a cost-effective way to screen. But it all depends on the economics of the particular country, how much value they place on the citizen, and what is the what is the quality adjusted life years. It's all economics, as you said.
After listening to you, probably in decision making of screening program, I think particularly in India, the radiologists are not involved. That brings down to most of it, if you see, it's the clinical examination, and nowhere the radiologist is involved in any of the task force, which is actually a sad part of the story. Across the globe, I mean, they speak about genetic testing, BRCA testing, you do all that guidelines, but then the radiologist is involved. But in India, that's actually, I think, someone like you shouldn't be on the panel all the time to make this kind of cancer screening program.
Let me answer one question. The genetic alterations that drive lung cancer are incredibly important, but the value of these genetic alterations is only valid for advanced cancers. If somebody has a very early stage cancer, stage 1 cancer, there is no guideline from NCCN to do any molecular testing on the samples. They don't get any adjuvant therapy. In these patients, surgery is curative, so genetic alterations are not tested. The routine testing of the underlying genetic alteration which is driving or driver mutations is typically for advanced cancers or those cancers which require adjuvant therapy. Even in those settings, mostly for stage 2, stage 3 cancers, adjuvant therapy is chemotherapy. The role of targeted therapy is not very clear. But very advanced cancers with distant metastasis, then if they have a genetic alteration which is driving the cancer, then it makes sense. But the purpose of screening is usually to detect early cancers which are cured by surgery alone without any adjuvant therapy. So genetic alteration is a good idea, but it is more valid for advanced cancers.
Well, if there are no other questions, thank you very much for that excellent presentation, and thank you all very much. Let's give a round of applause.
Thank you to our respected chairpersons, and thank you, Dr. Subha Digumarti sir, for your low dose but high impact presentation.